The second day of the American Academy of Nursing Virtual Policy Conference begins now. Welcome back, President of the Academy, Eileen Sullivan Marks.
Good day. I'm Eileen Sullivan Marks, President of the American Academy of Nursing, and I'm pleased to welcome you from my home to yours to Day 2 of the 2020 Virtual Policy Conference. Yesterday, we heard from incredible individuals who are leading with purpose and advancing meaningful change in the most challenging times. Working together and sharing the collective strength of our individual talents has been a guiding force to battling the pandemic. The ingenuity, persistence, passion, and compassion displayed by nurses and the healthcare workforce around the globe will continue to change the tide as we face COVID-19, inequities, and a myriad of challenges head-on. In the afternoon, we had the opportunity to open our minds, work to understand more deeply, and commit to ways we as leaders can eliminate racism and fulfill our mission to achieve health equity. I would like to personally thank all of the amazing and inspiring speakers who shared their wisdom and expertise with us. While we do not know what 2021 will bring, we do know that we must not lose sight of the need to change and evolve. The pandemic has spurred greater reliance on technology and accelerated how we use technology to provide care. Today, we will hear more about leading in a digital world and what opportunities are ahead for our profession. Continuing our important conversation on diversity, equity, and inclusion, we will also hear from leaders dedicated to creating inclusive healthcare environments. The Academy is committed to celebrating our different perspectives, which helps us grow and understand the unique experience we have to offer to the public, to policymakers, and to each other. The 3 concurrent policy dialogues hosted by our expert panels will further advance these important topics as they discuss 3 topics: defining the social and environmental determinants of health to achieve health equity, ensuring accountability for consideration of sex as a biological variable in research, optimizing ethical work environments throughout healthcare in a pandemic. Tonight, I look forward to celebrating our incredible 2020 living legends, Doctors Linda Aiken, Bobby Berkowitz, Kathleen Kitty Buckwalter, Beverly Malone, and Marilyn Rance. You will be inspired by their words and the hope that they bring to our profession and the future of health and healthcare. Remember, the ceremony is open to the public and will stream on YouTube so that everyone can celebrate these legends. As you continue to engage throughout the conference, please take time to visit the exhibits and poster presentations. Thank you for being part of our second day.
During our next panel, Leading in a Digital World, Innovation, Care, and Equity, we will hear from health technology leaders as they explore the advancements and challenges technology presents while encouraging attendees to consider how to use their leadership capability to advance innovative, equitable care in this increasingly digital world. We are pleased to introduce our moderator, Rhonda Collins, Chief Nursing Officer, Vocera Communications, and our 3 panelists, Kelly Aldrich, Chief Clinical Digital Officer, Center for Medical Interoperability, Elise Sweeney Anthony, Executive Director, HHS Office of the National Coordinator, and Christy Henderson, Senior Vice President, Innovation and Telehealth at Optum Health at United Health Group.
Good morning. I'm Rhonda Collins, and welcome to our expert panel discussion of Leading in a Digital World, Innovation, Care, and Equity. Technology continues to increase the interconnectedness of our world, yet the disruption of traditional methods of connecting, such as face-to-face interactions, can leave people feeling disconnected or at a disadvantage, especially as the pandemic propels all aspects of life to an online environment. From teleworking to telehealth services, virtual and mobile technology allows providers to institute creative approaches to treating patients and seemingly facilitates greater access to services, especially within rural areas. During this session, health technology leaders will explore the advancements and challenges technology presents while encouraging attendees to consider how to use their leadership capability to advance innovation, equitable care in this increasingly digital world. Our first speaker today is Elise Sweeney Anthony, the Executive Director of the HHS Office of the National Coordinator.
Hi, everyone. Thank you, Rhonda. It is a pleasure to be here today to talk a little bit about what ONC has been doing in the realm of patient access, interoperability, and supporting the needs of the clinician community. When I think about the care continuum, nurses and the nursing practice is so important to everything we do. We try to think about the continuum of care and everything that patients need, as well as clinicians, to support that overall improved health of the individual, improved access, and improved communication between the care community as well as the patient. So let's go ahead and get started. On the first thing I want to do is provide a bit of a note in terms of our work and the slide itself. So the materials contained in this presentation are based on the provisions contained in 45 CFR parts 170 and 171. While every effort has been made to ensure that the accuracy of the restatement of these provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. Please note that other federal, state, and local laws may also apply. This communication is produced and disseminated at U.S. taxpayer expense. This is also a great opportunity for me to put a plug in for healthit.gov, because while this presentation is going to provide an overview of the work that we're doing as part of the Cures Act implementation, there is a lot to look at. There's a lot to learn. There's a lot to dig into. So we have webinars, we have fact sheets that deal with particular sections of the Cures Act. So feel free to take a look at that. And of course, take a look at the rule itself. I, of course, love reading rules, but I understand that everyone does not do that as their day job. So we do have some resources available that can help you kind of pinpoint areas of interest for you. Okay, and going, let's see, to the next slide. So the Cures Act in a nutshell, how do you think about the structure of it? So it's important to think about the Cures Act in terms of enabling the movement of information in an appropriate way. And there's two main sections to it. One are the Health IT certification program updates and the conditions and maintenance of certification, and also the information blocking provisions. And under the 21st Century Cures Act, which is where the authority comes from for these updates that we're providing in terms of information blocking, for example, that is where the new authority and the scope for ONC comes from. So looking at the certification program first, I want to highlight a couple of things. The first thing to note with the certification program is while we're discussing and looking at this today as the clinical community, as the nursing community, it's important to know what developers who are providing you with your health IT tools, your EHRs, for example, are held accountable when they're certified under the program. So that's why I want to start there, because what the developers are held accountable to doing supports your care delivery. And that's one of the goals that's laid out in the Cures Act and then also in the implementation rule that we just completed. The rule, by the way, was finalized in the spring. We included some timing extensions that were noted due to COVID-19 and the fact that many are working on the ground to support COVID-19 response. So what we wanted to do was make sure that we put appropriate extensions in place because of that. In addition, we continue to consider where COVID-19 is in terms of response and implementation as well. And that's an ongoing process for us. All right, so looking at the conditions and maintenance of certification requirements, and remember, these are things that the health IT developers who are providing you with your technology as certified under our program are required to do. So through the 21st Century Cures Act, identified 7 conditions of certification and maintenance of certification requirements. And I'm just going to highlight a couple. One is that if you're a developer under a program, you should not be information blocking. And while that sounds very simple, it's very important to the care community in terms of what they are delivering and able to deliver. If you are treating a patient in your hospital system or in your pediatric practice and you need information from another hospital system or another pediatric practice, getting that information should not be blocked. And we want to make sure that that information is moving regardless of whether there is an affiliation between that other hospital system or not. And that's a lot of what Congress and ONC heard in terms of some of the concerns in terms of information moving. In addition, just to highlight a couple more, communications as well. We heard that gag clauses, as they're kind of colloquially called, are where the users of health IT are not able to talk about the products because of what are perceived or actual language in contracts saying you can't talk about a particular problem that you're having with the technology. So what we've laid out in the communications provision is providing the fact that those communications should occur. And there are some situations where it does not occur, and appropriately so, but we want to make sure that those communications are able to happen whenever appropriate. So we've highlighted provision on that. Real world testing is another one, making sure that the health IT that you're using has been tested in the environment it's going to be used. So not just tested in a lab type of environment for testing, but also tested in the real world environment. And that's really important. And let me just highlight the last one, the EHR reporting criteria. One of the other requirements that ONC has under the 21st Century Cures Act is to think about the EHR reporting program. Information that may be available from developers or from the users of the health IT about the product. And that's a program we've been working on implementing. We actually just released the user feedback criteria, and that's available on our website. And we're now working on the developer criteria as well. So once that program is up and standing, then we will go back and look at adding it into the rulemaking side of our house, as it were. And that would be through the conditions of certification and maintenance of certification. So let us talk a little bit about the U.S. Core Data for Interoperability. And I'm going to try not to use acronyms. That's why I paused for a second. I'm going to try not to use acronyms today. So the U.S. Core Data for Interoperability, we do call it USCDI, builds upon what we called before the Common Clinical Data Set. And that was the set of information that we believe should absolutely be able to move through these certified systems. So from your position as in the nursing community, having the information that you need is not just dependent upon whether it comes over to you, but whether it comes over to you from another practice or a hospital system or wherever it's located in a way that can be used, that can be opened up and used, integrated into your system or easily understood. And that's part of what interoperability is about. So making sure that we have a standardized set of that data and what that data, how that data should be represented is what the United States Core Data for Interoperability is all about. And it's not a process that's going to stop just there. The USCDI will be updated over time with the feedback from stakeholder community to tell us what else should be considered. And to find out more about that, my second plug for healthit.gov, you can go to that website and there'll be more information on the annual update process for the USCDI. All right, so information blocking, the other side of the rule. So the other side of the rule, information blocking, focuses on what Congress has laid out as a requirement for ONC. And that's around making sure that information is moving where it needs to go. And that it's not being inappropriately interfered with or prevented or materially discouraged that access, exchange, or use of electronic health information. So here are the elements of information blocking. There is indeed a definition that Congress has laid out in the 21st Century Cures Act. You'll also see that in the rule as well. Just to highlight some of those requirements, I just want to point out EHI becomes a very important part of looking at information blocking because there is a definition that attaches to it. In particular, the definition for the first implementation years of information blocking would be a smaller set of information. And this is where USCDI comes into play as well, because for the first few years of implementation, the EHI definition will be the data that is reflected in the USCDI. So that is not using the standards, but the data that is reflected in that information. And the goal there is to start with that set of information. But after that time frame is over, then the body of information that has to move would be a larger set of EHI, all EHI, that would be reflected through definitions that you may already be familiar with under HIPAA, for example, related to the designated record set. So we wanted to make sure, and we heard a lot of feedback about thinking about using existing definitions and regulatory constructs to support implementation of information blocking. And that's one way that we've done that. All right, so let's also talk a little bit about interfere with. And this is something that comes up in terms of what does it mean to block information? So looking at the definition of interfere with is an important part of that construct. As a clinician, you are able to say to a patient, hey, just so you know, I have heard that some concerns about a third-party app that the patient may be interested in having their information moved to. You are able to have that communication with the patient under the rule, and we talk a little bit about that in the rule as well. So I encourage folks to take a look at that. In some cases, delays may be considered an interference. But it's also important to remember that under information blocking, it's a case-by-case analysis. And this becomes important as we are thinking about who the actors are and what the overall landscape is as it relates to information blocking. So if we go to the next slide. So here, actors regulated in the final rule. And this is where part of where it's important to think about the case-by-case analysis. So healthcare providers, health IT developers of certified health IT, and health information networks and exchanges are subject to the information blocking provision. That means that there are penalties or appropriate disincentives in the case of a healthcare provider to which an actor can be held accountable to. Now, an actor is accountable to their specific actions as it relates to information blocking. So in an analysis by the Office of Inspector General, who will do a lot of these investigations into information blocking, the things they would look at is who is the actual information blocker? Is it the healthcare provider? Is it possibly the network or exchange? Or is it the developer of certified health IT? And that would be a factual analysis that takes place. So that's important to consider. The other important thing to consider is that there are different knowledge standards that apply. So for the clinician community, the knowledge standard is a nose. So did you know that the practice that you were doing was unreasonable and likely to interfere with, prevent, or materially discourage access, exchange, or use of EHI? In the case of health IT developers of certified health IT and networks and exchanges, then the standard is different. It's knows or should have known. I do want to spend some time looking at the providers. I think this would be of interest to the community. So I wanted to make sure I shared who the providers are. So the definition of healthcare providers comes from the PHSA, the Public Health Service Act. And there you'll see that there's an existing definition for healthcare providers, and that's what's used in the rule. And you can see here that skilled nursing facilities, practitioners, rural health clinics are all among those considered to be actors under information blocking, including pharmacists and pharmacies. So you can see that the definition is broad. And of course, the goal is to support the appropriate moving of information across the landscape to support the needs of patients. And let's look really quickly at the information blocking exceptions. So one of the things Congress asked HHS to do is think about what are the reasonable and necessary activities that do not constitute information blocking. Why is that important? Because we recognize in our implementation, and as you can see through the Cures Act as well, that there are situations where information should not move. And we understand that. So the exceptions allow for common sense approaches to that. So thinking about if you as in your practice, for example, have concerns about the sharing information because there could be harm to an individual if it is shared, or that there's a privacy consideration why the information does not move. For example, a state law that says that information should not move, or there's a security concern, or in some cases, it's infeasible because of the system you have. And in other cases, health IT performance could be that your system was down for a particular day, and that's when the request for information came in. So you couldn't send it that day, but you did send it the next day. So for the day you didn't send it, that would be a consideration as to whether you are subject, you can use an exception as to why that information didn't move, and thus you would not be considered an information blocker. Likewise, on the other side of the slide, you see that there are some exceptions that involve the actual movement of information. So think about content and manner, for example. We heard resoundingly through comments that it's really important for us to help and lay out what's the set of information that has to move, and we talked about that a little bit, electronic health information, but also the manner. What are the mechanisms? So first, and two entities, the user of the health IT, so think clinician community, and the developer of the health IT can come to an agreement about what they think, how they want the information to be received, including agreements around fees. If they can't reach agreement, then the information should still move. And we lay out a rubric, what we call the alternate manner approach, for that information to move. And it starts with thinking about using standards that are identified by ONC, or using standards that are identified by standards developing organizations as well, and also considers fees and licensing rubric for how and fees and licensing constraints should be applied in that alternate manner scenario. So taking a look at, now we have a little bit of a background on the concept on information blocking generally. the consequences of information blocking are also important to be aware of. So for developers and networks and exchanges, and those are all defined terms as well, under the rule, they are subject to $1 million per violation and civil monetary penalties. For healthcare providers, it would be appropriate disincentives. And HHS is still considering what those appropriate disincentives should be. Those would be established by rulemaking. And then also for those developers under the program, they could be subject to a certification ban if they are in fact information blocking. The other thing to note is Congress laid out in the 21st Century Cures Act that there are certain protections from the disclosure of information. So I've included the slide. Feel free to take a look at it, and you will see that there are certain protections laid out regarding the sharing of information blocking that could reasonably be expected to facilitate identification, et cetera. So I do encourage folks to take a look at this slide as well. And now a couple of resources. So I did two kind of plugs for the website, but here's another one. So take a look at this website, because not only can you provide an information blocking, give us some information about information blocking you may be seeing. You can find webinars. You can find information around what we are doing, what's coming up. If you're interested in the extension that we've laid out already, you can take a look on our website, and we have the timeline adjustments for the extensions we have provided for the certification program. No extensions have been provided as yet on the information blocking side of the House. As I said, we're always open to hearing where there are concerns regarding the timing of implementation. So you can always feel free to let us know. And from the feedback perspective, the mechanism for providing feedback on the rule, as well as many of the things that we are doing at ONC, is through our feedback portal, and you can see that link here as well. And that's it for the presentation. So I do want to thank you. I know I went through a lot of information. My goal was to provide highlights, but I'm always here, and I'm happy to provide more information and talk more about the things that we're doing at ONC. And we always love feedback, hearing what's happening on the ground. It really helps us to develop policy that really works. So thank you.
Elise, thank you so much for that excellent presentation. The really important information that you provided for us, and I know that all of the listeners will really benefit from it. So thank you for your time and your expertise. Our next speaker is Kelly Aldrich, the Chief Clinical Digital Officer for the Center for Medical Interoperability.
Thank you very much, Rhonda. It's a real pleasure to be here today with you all and have the opportunity to speak about the work being done and the challenges that we're facing around interoperability with medical devices within the episode of care. So as you heard, I work at the Center for Medical Interoperability. We are a 501c3 nonprofit cooperative research and development lab. We were founded in 2013, and we are located in Nashville, Tennessee. Founded by health system CEOs to simplify advanced data sharing among the medical technologies and systems of care. Now, it's important to note that the CEOs who gathered to create the center are working not only on behalf of their own healthcare systems, but within the industry as a whole. So they have dedicated resources here in the lab for solving shared technology and technical challenges. We are guided by advisory committees made up of clinical experts from within the healthcare systems, as well as technical experts within the healthcare systems and industry. The team has worked on developing reference architectures, which just means technology that allows seamless exchange of data. We have worked on implementations, testing, and certification and verification programs that are open source and publicly available on the websites. We are a centralized, vendor-neutral lab, and we have the approach where we take no funding from vendors, but we work, again, on behalf of the healthcare systems in performing technical work that enables person-centered care. We have a robust testing and certification process around medical devices and focused on promoting adoption of scalable and secure platforms. Now, we are here today to discuss leading in the digital world, innovation, care, and equity. Providing a common definition is important to navigate to outcomes. But the trouble is that depending on what role you are within the healthcare systems, you have a different definition of interoperability. So example being, if I were a nurse practitioner taking care of chronic patients, I may have different information and data needs than, say, a circulating cath lab nurse might have. So that's really important to note. We at the center see interoperability as the ability of information to be shared and used seamlessly across medical devices and systems to improve health and care coordination. What's interesting to note is that other industries have already agreed upon common definitions for interoperability within their industries. So they have centralized lab to manage compliance for this technology. The example is the UL labs. We're familiar with what that allows us to do with portability, getting electricity, plugging in our devices. And you often hear people talk about, wouldn't it be great if we had a seamless exchange of data, kind of like the banking industry does? I often hear the example of banking used from caregivers that they would like the equal ability to access data and information. So the banking industry actually demonstrated this innovation and growth by creating a common under the hood foundational infrastructure that is a common platform that all the banks use in order for us to access our funds. Another example is the cable labs. So cable industry 20 plus years ago decided to get together the CEOs and they said, we can't keep competing on the infrastructure of what we're offering to our customers. We have to come together with a common platform so that we can have data liquidity, exchange of data, and quite frankly, that allowed them to innovate on top of the platform that is common. And as a result, we have wonderful things like Netflix and other high-speed internet. So the modernization of technology must be plug and play, standards-based, one-to-many, two-way, as in every other industry except for healthcare. We need this to achieve high reliability, repeatability, affordability, and scalability. So here we see on this slide what most nurses agree with what they're seeing is current state. This is unfortunately a typical critical care unit, intensive care unit, where I spent the majority of my bedside years taking care of patients in this environment. What I would often say and what I share with the board of directors and many visitors that come to see us at the lab here at the center is I was actually interoperability as the caregiver within this episode of care. That isn't necessarily what we would recognize as a modernization to an environment. So that is the goal, is to modernize how these medical devices are sharing data amongst this episode of care around this patient. So there was a study done in 2013 by the West Health Institute in San Diego, and they determined that we could save in healthcare annually more than $30 billion in savings if we were to have a common modernization infrastructure or shared technology where simply medical devices could coordinate care. The impact of scaling solutions would become more affordable to all, including critical access facilities where equity of care should be supported and advanced. What I see when I look at this picture is not only a patient laying in this bed, but I also see 13 screens with individual data elements that require management to support this patient's care delivery. What I see is 13 screens for the care team to coordinate, document against, and to manage individually. What I see are 13 screens for, frankly, bad characters to potentially cyber hijack and cause harm. What I see is not a modern technology, but siloed data that causes burden on the care team. It impacts care coordination and outcomes for patients. With siloed data that does not coordinate care but stands alone, when I hear about research for transformation or artificial intelligence technologies or improving the episode of care, I think of this. I know there is a better way to work with policy for promoting interoperability. Patients and care teams really deserve better. And it is for this leadership awareness and acknowledgement that we must work together to improve the total lack of interoperability that does compromise patient safety, undermines the care quality, outcomes, and equity of delivery, and contributes not only to clinician fatigue, but quite frankly, to clinician burnout. We have to address the cost impact and waste elimination that needs to be organized and recognized from within the episode of care. We have to address cybersecurity risks, useful versus useless data. We live in an EMR-centric model of care delivery, and that has to change. We need to address interoperability to measure outcomes and impact, learning, reliability, and repeatability. I'd like to share with you our lab, which is what you're seeing here today. Our engineering team, along with the technical committee, have engaged with over 40 vendors who have individually signed intellectual property agreements to work with the center and the healthcare systems on the behalf of the industry to improve equity of care through creating the testing and specifications that the technology elements allow for data exchange. We acknowledge semantic, syntactic, and secure interoperability. The team has coordinated multiple interoperability events where different vendors would demonstrate data exchange that are published in a way that the rules and the specifications are known to all of the medical device companies, and they can still, upon this common reference architecture, exchange data. These rules are available, these specifications are available publicly on the website medicalinteroperability.org. So there has to be a balance that must be considered in driving success. If our goal is to achieve person-centered care, each element listed here plays an equal role in order to impact innovation that improves how we leverage technology to improve in a holistic and equitable manner. So thank you for having me. I look forward to the discussion with all of you.
Thank you, Kelly. Our next speaker is Christy Henderson, the Senior Vice President of Telehealth and Innovation at Optum Health at United Health Group.
Thank you, Rhonda. I'm so glad to be here with you all and talk about my favorite topic, which is virtual care. Virtual care has become just an increasingly important component of today's healthcare environment. Not only are clinicians and patients and nurses like you all more comfortable with virtual care tools, but it's really now proving out to be an effective method to be able to serve a multitude of needs across healthcare continuum. And during the pandemic, we really saw not only the possibilities, but became really reliant on telehealth. And it opened our eyes to the real possibilities and promise of telehealth. So one case in point is just from my experience here at Optum. And so I'll say that back in 2019, we had less than 1,000 telehealth visits delivered. So it was really just a novelty. It was not mainstream. But as you can see here, we had an amazing focus on how do we deliver the care that we need when our clinics are closed or people are scared, or even it creates risk for them to come into the clinics. And so over just a matter of weeks, we were able to bring about 15,000 telehealth providers online to be able to deliver care to those that needed it, which resulted in now what is right around 1.3 million telehealth visits in just about a 3 to 4 month period of time. So 1,000 last year, and just in about 3 to 4 months, 1.3 million video visits. That doesn't even count the numbers of visits that our telebehavioral health specialists did, which is about 22,000 providers delivering access to mental health services to those that need it. So we had this reliance and a 4,000% increase in our telehealth visits, which is not any different than what we're seeing in every health system and other telehealth provider groups across the country, this rapid increase in reliance on the technology. And so we also see that that's transferring over into investments, and you're seeing lots of mergers and acquisitions and IPOs, and there's just amazing funding going toward telehealth. And so we have this opportunity to take this horrific event of a pandemic and use technology to really modernize and advance the healthcare delivery model. So it's really exciting to think about, but I really want us to make sure that as we're doing this and as you all look at your profession and how you can contribute to redesigning healthcare and our new, what seems to be our new norm amongst a pandemic, I really want to focus on 3 key areas, which is around experience, intelligence, and impact. When we think about being high tech, some people will think about that being a cold experience, but we can also still be high touch, but just be more efficient and engage with people in a different way. And so first, let me talk about experience. We need to make healthcare easier. And before the pandemic, we had all types of barriers that were prohibiting that. We had to do certain things to be able to check certain boxes, and we had to be able to do certain documentation to be able to bill for certain things. And all those rules were there for a reason. But we now have a chance to step back and say, wait a minute, we can do this differently. And during this pandemic, we've had waivers put into place for the public health emergency that have really freed us up to think differently. And how do we want to create an experience that is not only great for our patients, creating a seamless experience, but really great for our clinical team. There's a lot of burden on clinicians and nurses at the bedside trying to fulfill all the needs of very complex patients. But technology should make things easier, not more difficult. And just as we've heard from our last speakers, we have things that we need to comply with, but we also have ways to think about interoperability and data liquidity so that we can change the experience. So it can be as simple as our banking experience. And we have a lot of opportunity there. And I've seen it firsthand that it's possible during this pandemic. The other area that I'll talk about is intelligence. We're getting data from so many different places. And as we think about now people using their personal devices and having, other sensors in their homes that are providing more information, we've got to think about how do we use that to make actionable information instead of just loads of data that we can't actually even have time to look at and process. There's ways to use the analytics and to create usable information. So these disparate systems can create patient profiles that really enable care teams to be smarter and deliver more personalized service. Lastly, impact. It's easy to get into what I said on the very first slide, which is around this increase in utilization of technology and telehealth visits. But really an impact is about us achieving the quadruple aim. And so how will we use this technology to change how people engage, to change behavior that leads to healthier action and prevention, and having earlier intervention so that we can change the whole trajectory that people are on. And doing all of that, lower the cost. So we're talking about the quadruple aim. How do we use the technology in a meaningful way and adjusting that to provide personalized health care to have a really big impact. And I think that one of the pieces that I think is so important is that healthcare is personal. And what I need today or what you need today may look much different tomorrow. And so the technology allows us to ebb and flow and be able to turn up and turn down how we engage with people based on those needs. So the technology is going to become even more important as we move forward, and the data just increases. We have to have that intelligence to be able to make it meaningful and useful. So the future of healthcare truly is data-driven, digital and accessible, and it's about whole person health. We don't want to treat components of an individual like just their behavioral health needs or just their cardiology needs. It's really about taking in all of that and so much more, their environment and all the social determinants of health. And technology allows us to do this. So we can begin to engage with people on this journey to health in the way the traditional system was actually unable to do so. Simple reminders and nudges, one-click tools to video care, and personalized self-care tools and digital therapeutics have a great promise. With technology, we can deliver structured, high-quality, and high-impact healthcare to people when and where they need it. By leveraging data and analytics, we can align each person's unique needs with a highly personalized health program that offers the right blend of human and digital support for individuals ranging from those with low to severe health needs. And as we advance in this digital world and we all try to figure out how to use this technology in a meaningful way, we'll need to be very intentional about health equity and how we deploy these tools. That means that we need to have creative solutions like curbside telehealth and home delivery solutions that provide the devices and the connectivity that's needed for those that have none. I've seen firsthand how telehealth can help deliver improved health care and how it actually can be delivered in any kind of disparity. So whether it's in a rural area or underserved area or to seniors or those with complex needs, I've seen effective solutions deployed, but we do need to be intentional about how we do that and making sure that there is equity in how we deliver this. There are so many unknowns, but one thing that is known is that we're living in a digital world that holds great promise for healthcare. So when I talk about all this technology, I really want to bring it back to just a scenario, a common scenario. Every one of us can think of either a patient that we've cared for, how technology could have been used to have made their journey a little easier, or our own personal situations that we're dealing with. But let me tell you a story here. We have Julie, who's a single parent of 2 children. She's also caring for her aging father who wants to live alone longer. He doesn't want to have to either move in with her or go into an assisted living facility. But the reality is that she has one child that is getting behavioral therapy on a 3 times per week for 6 weeks. She's working. And then her father that she's caring for, who has heart failure and diabetes, recently had a fall and had to have a hip replacement. And so he was brought home and now is discharged from the hospital back to the house. But in a digital world, what this looks like today and how it could be changed is that her father, when he returned home, receives a remote monitoring kit into his house, which has devices and a tablet that has a data plan so he can connect in and talk to his nurse. The nurse can monitor his vital signs, can check on his symptoms, can even look at his wound, his surgical wound, and can really be proactive in coaching him back to health. All the while, his daughter, Julie, can actually beam in on the video call with her father and the nurse, and so that they can actually interact in a safe environment. But she has peace of mind that she knows her father is being tended to. He is also has that comfort, but he's able to live at home even longer. Meanwhile, those therapy visits that used to take Julie away from work for a couple of hours and her child away from school to go to a behavioral health appointment now are done over video. So she can have these at the convenience of her home. The child feels more comfortable in their environment as well, and they can interact with the therapist as a family. Amazing opportunity that frees her up from so much time that she actually can get her wellness visit as well through telehealth. So telehealth is not just a simple video visit for an urgent care. It really is tools across the entire care continuum that, as you see in this one family's journey, can really make a huge difference so that we don't delay or postpone care, and that we can have it at the convenience of our fingertips with one click of a button at home where you can connect to your care team. So as I think about a call to action and what we can do as we're moving forward, we have an incredible opportunity that we can take this horrific event of a pandemic and find the silver lining in that. And during this time, really sit back and reflect on what we learned during this rapid deployment of telehealth during this pandemic. And really think about how we should make it a more permanent infrastructure to be able to support this and the use of digital health tools. We really have to think about progressing in a way around access to care, around improving the quality of care, around reaching those that have no access to care, and really thinking about making it easier so that we can get to really a modern digital health world. The industry has made incredible advancements over the last several years. We've had the tools increased. We've seen a reliance in the possibility. We've had lots of publications showing the positive impact and the cost savings of telehealth as well. We've seen standards of care get redefined to be able to acknowledge that care can be done over technology, that we can actually do a remote exam using connected devices so I can listen to heart and lungs, look in eyes, ears, and throat. It's more than just an audio and visual that we're doing just like right now. We've seen the cost savings. We've seen people become dependent and reliant upon it, but now we really have to go to the next level to really make it a mainstay and make it mainstream in our operating models. That means we have to redesign how we operate in clinics. How do the clinicians and the care teams and the nurses and social workers and pharmacists use this technology and blend it into their practices in a virtual as well as an in-person environment? We're not done. We have a lot of work to do while we've had a lot of progress made all during a pandemic. The waivers have cracked the window for us to be able to really explore these possibilities. It's now up to us to open the door to all the full potential and unlock that for all of us to be able to deliver care in a digitally enabled health ecosystem. We have a huge opportunity here. So I'd ask us all to be able to, within our organizations, whether it's through policy, whether it's for advocacy, educating our patients, educating the rest of our care team, we have a possibility to really advance this to a modern, digitally enabled health ecosystem. So I'm excited about the possibilities and find really this is a silver lining during this horrific time. So I'm excited to see where this goes from now of how we can really make a difference for those that we serve. So thank you, Rhonda. I appreciate you having me here today.
Thank you to all of our outstanding speakers, and we will now move to our open question and answer time.
Hi, everyone. It was a pleasure to present a little bit today regarding health information technology and the work we've been doing at ONC, and a pleasure to hear from so many of the great things that the panelists are doing. I did want to share and ask Rhonda for just a second, just to mention an update, sit a little bit behind the curtains, shall we say, because when we recorded the presentations, we did not have an update from ONC, but yesterday, we released and posted on our website a new interim final rule. And I wanted to take a second just to provide a little bit of background on what that rule covers, because it is very much related to what I presented on. And that relates to the implementation of the CARES Act final rule, specifically around the extension of deadlines and applicability and compliance dates that we've laid out. So as I noted in my presentation several times, and I'll continue to do it, we have tons of resources on our website, and we have included a couple of new fact sheets that relate to the extension. But let me just give you a couple of updates. So the interim final rule that we released yesterday on our website has not been published in the Federal Register as yet, but when it is, it will be effective immediately. So take a look out for that. We'll update our website regarding that as well. And it really is to provide additional flexibility and time to effectively respond to the public health threats posed by COVID-19. We've heard a lot from stakeholders regarding their commitment to the CARES Act final rule, but also that they are also responding to COVID-19. So the dates that we've updated include the information blocking applicability date, which now moves to April 5th, 2021, from what would have been Monday, November 2nd. So the new date is April 5th, 2021. In addition, there's many provisions with dates in the CARES Act final rule have been moved to December 31st, 2022, as it relates to the Health IT certification program requirements. But take a look, because there are several date updates to look at, but I did want to highlight a couple here. The interim final rule also does a couple of other things, such as update some of the standards and make some technical corrections. Again, I know that everyone does not read rules all day. This one is much shorter than the other ones, but we do have some fact sheets. And most importantly, on Monday, we will have a webinar. At 3 p.m. on Monday, ONC will host a webinar which goes into in-depth what the interim final rule covers. You can find information on how to register on our website, healthit.gov. So a brief interlude, and hopefully that might answer one or two of the questions that come in regarding our work at ONC. And with that, let me go ahead and turn it over to Kelly, I believe.
Right. So thank you very much. Go ahead, Rhonda.
I wanted to go ahead and transition to the Q&A period and thank everyone for the excellent and informative presentations. I appreciate everyone's participation, and those of you who have been listening, I hope that you learned from it and you are ready with questions for our experts here. I'm going to go ahead and go over to Kelly and ask the question, can you provide recommendations on how we can make the case to our IT colleagues, leadership, and other decision makers within our organizations to champion interoperability?
Right. Thank you, Rhonda. So let's just face it, everyone is a champion. We all need to take part to improve interoperability. Interoperability is both simple and complex. It's simple because we all know that the systems don't talk to one another. And it's complex because how do we fix this? But what I'll share with you is that my CTO constantly reminds me that fixing the interoperability around the episode of care or care transitions, that it is not a technology problem. We have the technology to do this. That we are faced with policy issues that prevent or stop us from sharing data. We have rules that ask for one-way data flow when we need two-way data exchange that will allow for research and more exploring of improvement of the environment of care. But it's very complex because we're not able to start with a new slate. We have to add the technology as fast as technology is evolving in other industries into healthcare. That is very challenging to do, and not to interrupt the clinician's workflow processes, not to create more burden. We're dealing with, from an operations IT perspective, we are dealing with hospital buildings that could be 50, 75, 100 years old. How do you get the best wireless infrastructure in place? How do you get medical devices that perhaps your facility or your organization can't afford to buy a new fleet of monitors or a new fleet of EKG machines that allow for more advanced technologies. We need to consider this. And what I would suggest here to this group in particular is we need to lead the requirements. We need to identify what the correct definition is, what the ideal state is that we're trying to achieve, and then close the gap. Create a strategic and tactical roadmap within your healthcare organization or your environment by going out and surveying. Send students out, send yourself out, go look around, do your medical devices talk to one another? Is there a burden? Are there safety risks? Is there a lack of quality? We have to do this together. You have to partner with your IT folks to create plans. You have to engage with your informaticians and pull them out of the EMR-centric world that they're living in. This is a profession of clinicians, nursing informaticians that can help create these roadmaps. We need to make sure that we are utilizing their skills in this space. We have to be able to do this to modernize, to prevent the cyber attacks that are occurring to our health systems today. If you have ever been involved in a cyber hijack, these are just beginning. We have to be aware and engage. So for over 2 years, I have coordinated and sat on cybersecurity committees. I will tell you, when I started attending these committees, they were completely new to me. And getting engaged with the committee to learn about what the needs are, they want the clinician's voice. They want to understand what is it that we need, and they want to be able to remove those barriers to improve patient care. There are no IT folks out there that do not boast about being in healthcare. They love the idea of supporting clinicians. They love the idea of working with nurses. But if we don't give them the requirements to remove those barriers and decrease the burden, then they make decisions on their own. And that's when maybe we get technology that is not so useful, and we create workarounds. So I would say to this group, we need to examine those workarounds. We need to look in our environments, what is working, where is your ideal state? Ask your clinicians to identify what they need and create a roadmap. This is what we will do to transform the industry by working together in collaboration. So thank you, Rhonda.
Thank you so much, Kelly. I have a question for Elise right now that's related to EHRs and documentation. The documenting in the EHRs is often burdensome for nurses, and how will the Cures Act address this challenge?
So this is a great question. Thank you, Rhonda. Let me start by mentioning a provision of the Cures Act, which I did not get a chance to really talk too much about in the presentation, and that's the Clinician Burden Report. And that work is actually led on ONC side by Dr. Andy Gettinger. He's been working very closely with CMS, and they actually released a report related to clinician burden, and documentation was one of the things that was discussed in that report. The other thing I would note is, in general, we support an interoperable environment, including the use of API technology that uses the standards we've identified. And that's an important part of the equation as well, right? Because the more information can move in an interoperable way, the more it can be integrated into the system and address some of those concerns that have been raised. But I do encourage folks to check out the Clinician Burden Report that was released. The other thing I want to note, where we are thinking about this, is actually another release that we released today, actually, and it's the Federal Health IT Strategic Plan. The strategic plan covers the next 5 years. It was developed by more than 25 federal organizations, including CMS, who, as you can imagine, works a lot in the documentation space. And it is really focused on identifying how health IT across the federal landscape should be considered, what we should be thinking about, where we should be going towards, and of course, how to work with the stakeholder community community. There's a blog that we released online that provides a summary of that. We'll also be doing another webinar. As you can tell, I'm all about making sure that we're reaching out to the community and stakeholders to talk about the work that we're doing. So there'll be a webinar. The date will be on our website. I believe it is November 9th is the date that that webinar will be on. And then the other part I would say is it's really important to continue to hear from, stakeholders, the American Academy of Nursing, and what you're doing, and hearing how Health IT can help you and make your world and the provision of care that much easier. So continuing to have the conversations with us about your interests and how you feel about the work that we're doing is really important. I would also say that as we continue to move towards implementation of the Cures Act final rule, we want to hear from clinicians how best to reach out to you regarding sharing what the requirements are under the Cures Act, and more information that you think would be helpful in terms of resources. So feel free to reach out to me. I'm happy to talk to you all about that. My email address is elise.anthony@hhs.gov, but you can also check out our inquiry portal where you can send in any questions you have or specifics. And that's the best place to send in specific questions regarding the Cures Act, because that's the way we can look and figure out what informational resources might be helpful. So I hope that's kind of an overview, but as you can see, we're looking at the documentation issue from a number of different perspectives, and CMS in particular has been doing a lot of work to think about this.
So, Elise, before we let you go, just wondering, the question has been asked, what problems created the need for the work on information blocking? What are the issues that you've had to deal with?
Sure. The information blocking rule stems from the 21st Century Cures Act, where Congress actually lays out an entire section in the Cures Act focused on information blocking. There were a number of hearings as well as stakeholders who were reaching out to Congress, and we heard from stakeholders as well as the Office of Inspector General and others regarding instances of what appeared to be information not moving when it should have appropriately moved. So Congress put together this provision in the Cures Act looking at information blocking, defining the actors that would be covered, and then HHS then went forward with implementation from there. And of course, the goal is to support patient access. The goal is to support clinicians having the information they need as they are providing care. And all of that is kind of laid out in terms of the rule itself, but really it comes from the Cures Act. And the other thing I would say is before the Cures Act, Congress also asked HHS, and ONC provided the report around information blocking itself, and what are the instances, what are we seeing in the field in terms of that happening. So that information blocking report was shared with Congress and really laid out what we were seeing at the time. And that goes all the way back to 2015. And then, of course, the Cures Act came soon after in 2016. And then we've been working on hearing from stakeholders and going through the development process on the rule.
Okay. Thank you, Elise. I really appreciate that very informative answer. I just want everyone to know that we're having a little bit of difficulty with Christy Henderson, with Dr. Henderson. I'm not ignoring your questions about telehealth. We're just trying to get her back online. So we'll continue with the Q&A, and as soon as we can transition to Christy, we'll certainly do that. So Kelly, back to you. A question has come in about reimbursement. As reimbursement is tied to billing and billing is tied to charting, how will we ever get to true interoperability without a single payer system?
Thank you, Rhonda. What an interesting and great question. Prior to going into informatics, I was a chief nursing officer and was always dealing with the complexities in management of billing. I think that it's a broader question, quite frankly, and it is around the modernization of not only billing, but quality reporting, how in ways that we take data and build around those models in research and advancing practice guidelines. And so I would have to advocate for the modernization has to have a single common platform that is driven by secure rules and have compliance that gets you on and off of the common platform from within your healthcare. It's very expensive to scale and to adopt and innovate in technology. And we have to understand the holistic approach to interoperability and how will we be able to innovate on top of what we have. And we have to come together with that understanding. There's been a lot of work done around the information blocking, and we are very grateful for that, for those contributions in the Cures Act. The Senate Help Committee on Interoperability has been extremely supportive in this space in how we advance. And for this group, I think it's really important that we continue to advocate that the complexities of interoperability really needs to be reduced. And as I stated before, having strategic plans, partnering and collaborating with not only your IT folks, but your security divisions as well will get us into the next phase of where we need to go, which is modernization of platforms.
Thank you, Kelly. Do we have Christy? Okay, we've lost Christy again. I apologize. We have some great questions for her. If we can get her back online, we will certainly do that. We've addressed the cybersecurity questions. Let's see what else we have coming in. So anyone can answer this, either Elise or Kelly. What do we do about improving access to universal broadband access? Because as we know, fully 60% of our country is rural, and in many of these areas, there's no access to internet, or they cannot access healthcare online. It's really an inequity that we have in our society. And just so any thoughts or comments either one of you have around that, that's a great discussion. Kelly, you want to go first?
Sure, if Elise is there, I'm happy to kick us. Sure, I'll kick us off. Having connectivity is a problem not only in the United States, but internationally. I have the pleasure of working with folks from Honduras, the medical community, who too are challenged with this problem around getting improved data exchange in rural clinics that absolutely do not have internet. We've been working with local student groups, quite frankly, Open MRS, in order to create these platforms that are open source and available through satellite. I would encourage us and let you know that there is a lot of research being done in this space. It might not be highlighted or sexy to talk about, but these are really core essential things that we need to look at, which is how we come to, again, I'll say, the common platform that's scalable and secure. There are many digital societies that we can model after that have done this and through the international community. And the U.S., we need to continue to challenge what we mean by interoperability, data exchange, seamless data exchange in privacy, both two-way, standards-based, and equitable. So I'll see if Elise is there. I'm not sure if she's also having camera issues, but I'll see if she has any comments to add.
Yeah, I think Kelly, hopefully you guys can hear me. Kelly's point about interoperability and how we think about it, I think is really important. Why we focus so much on interoperability, why we focus so much on making sure that information is moving across the kind of exchange tubes, to put it in an extremely simple way. But thinking about how information is moving, that makes it more usable wherever it's going. We think about rural communities, we think about urban communities, and there's different needs at times, and sometimes the needs are similar. Christy, would be great to talk about kind of some of the telehealth benefits in that respect as well. But I do want to talk a little bit about TEFTA, the Trust Exchange Framework and Common Agreement. And I did not present too much on that during the presentation, but it's another activity that we are engaged in. And the goal is to provide a single on-ramp for information to be accessed from, like, let's say a provider perspective, let's say it's a hospital system or a practice who needs information on a patient who may not be located near where they are for several reasons. And being able to access that information through this network of networks enables information to get to where it needs to be faster so that care can be provided in the most informed way. So the Trusted Exchange Framework and Common Agreement is another activity. It's a policy framework that we're working on. We have a recognized coordinating entity who is working with us through a public-private partnership to build it out. It will actually be a common agreement that can be signed onto so that folks can be part of that kind of single on-ramp environment. I would love to talk more of that, but I know we have to close up. So I would encourage folks to check out our website. We have what's called a TEFCA user's guide, and it kind of lays out more about how TEFCA would work and how it can help in terms of accessing information in the provision of care.
Thank you. Thank you, Christy, Elise, and Kelly. I appreciate so much your time and your efforts and your presentations that have been so insightful for all of us. We're all asking ourselves, how can we improve access and quality of care for underserved patients? And especially the pandemic has certainly highlighted that for us. And as we move forward, just to look at the technologies that are available to us now, what we have, the expertise that we have available, not only in nursing, but in our complementary and colleagues across the world. As we look at how do we use what folks already have, how do we use the own technologies that they use every day, such as smartphones, such as their own televisions and computers, et cetera. These are all questions that we can continue to ask and we will continue to look at. And how do we create an interoperable world that eases the cognitive burden for the clinicians caring for our patients, that ensures that they have what they need at the time that they need it, and in the safest, most equitable way possible. Thank you again for your time. Thank you for attending this session. We do hope you found it valuable. And thank you again, Dr. Henderson, Dr. Aldrich, and Ms. Anthony. You have been fantastic, and I've enjoyed working with you very much.
Hello, my dear friends and colleagues at the American Academy of Nursing. I'm Kate Fitzpatrick, and I'm so honored to be able to bring you all a well-deserved mindful moment. How you invest in yourself directly reflects the level and quality of the ways that you can invest in others. My goal in the next several minutes is to guide you through a purposeful pause with the hope that it brings you all some inner calm and some centering, and that it lifts your spirits. I'm going to start this mindful pause with a bearing witness reflection. And these are words that I've written really just to reflect and give some meaning to what we've experienced over the last 8 or so months. And so I want you all just to imagine this time 1 year ago. No one, and certainly not me, could have conceived a future that looks like our present reality. As a global community of nurses, we prepare to celebrate 2020 as the year of the nurse and the midwife, as declared by the World Health Organization. Like many of you, I was involved in intense planning for months to try to determine meaningful ways to adequately acknowledge and recognize nurses more broadly and share the impact of our profession on humanity. Nothing we planned, for sure, would have come close to highlighting the essence of nurses and the ways the world saw us collectively respond to a worldwide pandemic. Nurses stood tall. We put aside personal fears and anxiety and showed our courage. We wrestled with inner doubts and said, yes, I can, and did. We observed the effects and devastating impacts of a virus on fellow human beings and found ways to show grace and kindness. We witnessed significant clinical, operational, educational challenges, and we innovated. We saw and experienced isolation in ways we've never seen before, yet we found ways to foster connection. We watched and bore witness to lives cut short unexpectedly, and we did so with dignity, compassion, and strength. No matter our role as a nurse, be it a clinician, leader, educator, I hope that you, like me, know that our impact has been seen, our profession has been acknowledged in ways that it never has been before, and know that your part of how you are responding in the past several months has made a difference. So I hope, like me, you take time to feel pride in the profound ways that nurses have shown up and demonstrated their competency, their humanity, advocacy, and their empathy. And so with that, I want to move our attention to our focus on taking this, as I said, very well-deserved and really important purposeful pause. And so what I'm going to do with you all today is lead you through what's called a body scan. And it's a way to just take stock, really focus all of your energy and your thoughts on yourself for just a few moments. Again, with the intent of trying to find some inner peace, some inner calm, and to center yourself. And so we begin by just having you all find a comfortable position. If you're sitting, try and find an upright and dignified position. Firmly plant your feet on the floor. Begin to notice how you are connecting with whatever surface you're in contact with. And just settle in to that space, wherever it may be. And I want you to start to disengage your mind from the busy thoughts and ideas floating around in your head. And I invite you to close your eyes or gently soften your gaze. Gently gather all your attention now to the center of your body. Begin to reel in all the thoughts that take you to the outside world and begin to bring them in close. Allow the outside world just to gradually melt away and dissolve into empty space. I ask you to start to notice and pay attention to your breath. Notice the way that the air moves in through your nose. Feel the temperature, the warmth of the breath coming in through your nose. And appreciate how the air feels as you exhale. And maybe just take a moment to do a few centering breaths in through your nose, out through your mouth. And give yourself the grace of taking breaths over several seconds, maybe a count of 4 as you inhale gently through your nose. And then exhale over a count of 4. And begin to really feel yourself become grounded. And so I'm going to invite you now to start to bring your attention to the area around the crown of your head. Notice and gradually work your way down through the surfaces of your head. Focus first on your scalp. Imagine all the tension and any of the energies or sensations that you feel now at the top of your head. Allow those to simply dissolve away. Focus next on your temples and your forehead. We tend to hold a lot of our stress in our face, oftentimes without even realizing how much tension we can hold there. But notice the tensions, notice any pains or sensations that you might have at this time around your forehead and your temples. And imagine them just simply draining down through your body and soaking into the ground beneath you. Imagine the tension next in your jaw, around your ears. And as you place your mind in this area, imagine any sensations that you have there, again, just simply dissolving away into space. And pause for just a moment and just appreciate having paid just a few moments attention to your scalp, to your jaw, to your temples. Appreciate now that your head feels lighter and more relaxed. And so we continue down, and I ask you now to really think about the areas around your neck and shoulders. This is another place where we carry so much of our tensions and our burdens, and physically we feel a lot of those effects in our necks and shoulders. So inviting you to relax your shoulders and take a moment just to gently lift them up and then let them down, lift them up again and then let them drop, and imagine all the tensions, build up worries, build up anxieties that you might be holding in your shoulders. Let them dissolve away. And begin to feel the tensions and weights that you carry in your neck and shoulders pass through you and be dissolved into the ground. Let the luggage of your daily life go. Relax your arms and hands and begin to really notice them. Appreciate any sensations, any feelings that you have in your arms or legs, any of the tensions of the day that you're appreciating now as you sit here in silence. And with kindness, just think about releasing any tension that you have in your arms, in your hands, your fingers, and allow them to float away. Now I'd like you to have your focus drawn to your back. And bring your mind gently to the top of your spine and focus on any of the sensations or tensions that may have built up around your spine and your back. Place your mind's eye there and really focus on allowing any knots or any tensions just to unravel and release. Let them dissolve down through your spine and exit through the soles of your feet and dissolve into the ground. As we mentally work our way down the spine, slowly relax and unravel any other knots or stresses that you feel in your lower back. And take a moment again just to appreciate how a relaxed and tension-free spine and back feels. And then we'll bring our attention around to the front of our body and focus on our chest and our stomach. And just notice any areas of stress or tension in this part of your body. Imagine that all the stressors and tensions that you may be holding here, with your gracious attention and focus here, can disappear and dissolve. Imagine any fears, any anxieties, any worries that may have been built up and holding in your stomach or chest area. Allow them to be released. And take a moment in gratitude to just appreciate a lightness and a chest and stomach area that are more relaxed and more comfortable. And then we'll bring our focus to our legs and our feet. Imagining any tensions in these areas just drain away. Our legs and our feet do so much to keep us upright and move us about in the world. We hold and can hold a lot of tension and stress in our lower legs. So imagine with some focused attention just allowing any areas of discomfort, any knots, any areas of tightness, just to relax and again allow them to gently drain down your body and exit through your feet. And then for a few moments, just think about your feet and your toes. They provide our foundation and our grounding to the earth. Take a minute just to wiggle your toes, to think about any tensions or any stressors or any sensations you might have in your feet at this moment. Allow these to be released. And then I want you to just savor a few moments with some cleansing breaths to enjoy this moment where your body has been given permission to release tensions and stressors and pain. And together, let's take a couple of cleansing final breaths with an inhalation through your nose, not rushing it, taking your time. And then gently exhaling. And then repeating that. And then just have gratitude for your body, for the way it helps you experience the world, for the sensations it allows you to feel. Be grateful for the work that you do. And we're going to begin to bring our awareness back to our surroundings. If you decided to close your eyes, I'm going to invite you to open your eyes again. Become more aware of your surroundings, your position in the room. Maybe take one more final breath as you re-emerge fully back in the moment and present in this space. I want to thank you all so much for taking time to invest just a few moments in yourselves. You certainly deserve it, and I hope you enjoy the rest of the meeting.
Our final panel of the day, Creating Inclusive Healthcare Environments, is a topic close to all of us at this time. The coronavirus pandemic has intensified the inequities experienced by marginalized, underserved, and vulnerable communities, especially as people of color continue to be disproportionately impacted by the virus. Today, we are honored to hear these influential public health experts about how assessment, policy development, and assurance, the core principles of public health, can steer thoughtful discourse and inform practical steps on how to transform the culture of care, guided by social justice, to be more inclusive of diverse populations. We look forward to hearing from moderator Kapiri Ackerman Barger, Associate Clinical Professor at the University of California, Davis Betty Irene Moore School of Nursing, and our panelists, Joseph Bertulfo, Director, Occupational Health and Safety Office at the Centers for Disease Control and Prevention, Ukamaka M. Oruche, Associate Professor and Director of Global Programs at Indiana University, and lastly, Annabelle Castro Thompson, Senior Vice President of Health Equity at Equality Health.
Hi, welcome to our session on creating inclusive healthcare environments. My name is Piri Ackerman Barger, and I'm going to be your moderator today. I serve as Associate Dean of Health Equity, Diversity, and Inclusion at the Betty Irene Moore School of Nursing at University of California, Davis. When envisioning the pathway to creating inclusive healthcare environments, it is apparent that stark inequities and systematic racism persist today and impede progression toward attainment of better health. The current dynamic provides an opportunity for nurses to leverage the lens of health equity to usher in change locally, nationally, and globally. The coronavirus pandemic has intensified the inequities experienced by marginalized, underserved, and vulnerable communities, especially as people of color continue to disproportionately be impacted by the virus. Hear from influential public health experts about how assessment, policy development, and assurance, the core principles of public health, can steer thoughtful discourse and inform practical steps on how to transform the culture of care guided by social justice to be more inclusive of diverse populations. Today, we're going to have three speakers. We'll have Dr. Joseph Bertulfo, we'll have Dr. Ukamaka Oruche, and we will have Annabelle Castro Thompson. I'm going to start off by introducing Dr. Joseph Bertulfo, who is Director of the Occupational Health and Safety Office at the Centers for Disease Control, the CDC. In his role, he is responsible for preparing CDC staff who are deployed throughout the U.S. for the COVID-19 response. This includes providing pre-deployment training on donning and doffing personal protective equipment, like respirators and gowns, and developing post-deployment guidance for returning responders. Dr. Bertulfo.
Thank you, Piri, and hello, everyone. I'm glad to have this opportunity to share how my role as an occupational health nurse in the occupational health and safety professions promote an inclusive environment when it comes to workplace safety. I've been at the CDC now for 17 years and took on this position as the director of CDC's Occupational Health and Safety Office a little over a year ago. Offices like mine are typically responsible for providing a safe and healthy workplace for all staff. This is accomplished through a variety of occupational safety initiatives that help minimize the risk of workplace hazards. And these initiatives include employee and stakeholder engagement, training, workspace assessments, communication, promoting an inclusive workplace, and finally, personal responsibility. So I'll go over each of those during my presentation. An organization's employees are the most important part of a safety program, and we rely on them to help us identify occupational safety hazards. One way to improve employee and stakeholder engagement on safety is to establish a workplace safety committee. The committee should be made up of management and non-management employees, as well as subject matter experts such as biosafety specialists and mechanical engineers. The committees work together to prevent workplace injuries and illnesses, and is an open venue to gather input from a variety of staff on how to improve an organization's safety program. So the key point here is by providing a platform for open conversation on occupational safety issues, the committee fosters an inclusive environment by bringing more people to important conversations about workplace safety. Another way we promote an inclusive environment is to develop occupational safety trainings that apply to all staff members, although some courses may specifically target unique working hazards. For example, most of our employees work in an office, and like many large campuses, we have things like cooling towers and mechanical rooms, so we provide specialized safety training tailored for those areas. But for any safety training, it's important to reflect the diversity of your staff and your training materials, including print and video material. So the key point there is to promote inclusion in the workplace. Safety trainings, and really any training, should be designed so that the diversity of employees is represented. Organizations should also conduct workplace safety assessments on an annual basis to ensure that the workplace is accessible and safe for all staff. Annual assessments include making sure access devices are in working order, such as automatic door openers. We ensure passageways are clear of hazards, workspaces are accessible for all staff, and building evacuation lanes remain clear. In addition, workplace safety assessments also help ensure organizations meet the standards set by the American Disabilities Act. For example, occupational health and safety professionals work with stakeholders such as facilities and construction teams when facilities are developed or updated to ensure ADA requirements are integrated into the construction process. And just this year, the ADA celebrated 30 years of progress in access and inclusion. So the key point is important to assess each workplace setting to establish that the environment is safe and accessible for all staff. When it comes to communication, organizations should communicate regular safety messages to help remind staff of safety guidance and policies, as well as to reinforce what staff learn from their training. In 1998, the U.S. Congress amended the Rehabilitation Act to require federal agencies to make their electronic and information technology accessible to people with disabilities. Under Section 508 of this Act, agencies must give employees with disabilities and members of the public access to information that is comparable to the access available to others. Now, while the Act only applies to federal agencies, it serves as a model for developing safety communications, training materials, and safety reporting systems. Safety messages should also be developed using plain language, as suggested by the Plain Writing Act of 2010, and in a variety of formats, so the information is easily accessible by all employees. So the key point here is that regular communication supports an inclusive workplace, especially when employees can access information in a way that is easily accessible for them. To promote an inclusive workplace, organizations can also sponsor diversity education programs that highlight how a diverse workplace strengthens their mission. So a good example is the National Disability Employee Awareness Month, which is celebrated this month. Occupational safety can play a large role in creating a safe workplace for individuals with disabilities. One example of this is conducting ergonomic assessments or similar evaluations to tailor the workplace for their needs, whether it's an adjustable workstation or providing closed caption devices. Key point here is that promotion of an inclusive workplace involves recognizing and celebrating the variety of experiences our staff brings to the table. Organizations can acknowledge the importance of a safe work environment for everyone, including individuals with disabilities. Finally, while large organizations rely on a multidisciplinary and inclusive team of occupational health and safety professionals and program support to ensure occupational safety programs are in place for their workplace, it's important to promote a culture of safety where everyone has the responsibility to keep their collective work environment safe and are encouraged to identify workplace hazards. Key point here is that organizations help to educate and promote work practices to provide a safe environment for all employees. And in turn, each employee has a personal responsibility to contribute to workplace safety. Before I close, I want to recognize that this is a time where many people are taking precautions to stay safe because of COVID-19 and patiently waiting to return to the workplace. Occupational health and safety professionals are doing everything they can to ensure a safe workplace for all. For example, we're making sure at CDC, we're making sure hand sanitizers are easily accessible. We're helping draft work policies that offer flexibility to high-risk individuals who may not be ready to return to the workplace. And if furniture is reconfigured to promote social distancing, these spaces meet the needs of all staff and not just a one-size-fits-all. So in closing, I want to recognize all my fellow nurses who are in the field every day caring and healing for those affected by COVID-19, as well as my colleagues at CDC who understand that efforts to improve public health must be inclusive. CDC is a 24/7 agency, and for the COVID-19 response, many of us work weekends and after hours to support clinicians like you and public health professionals at the state and local levels. This is a very dedicated group, and I'm proud to work alongside them every day. Thank you.
Thank you so much, Dr. Bertulfo. That was a wonderful presentation. We really appreciate your insights and contributions. Next up is Dr. Ukamaka Uruche. She is Associate Professor and Director of Global Programs at Indiana University School of Nursing. A nationally recognized expert in psychiatric nursing, Dr. Uruche has made sustained and exemplary contributions to our understanding of the challenges experienced by families of adolescents with mental disorders. Her cutting-edge research ensures that mental health needs of family caregivers are given full clinical consideration. It's a pleasure to have you here, and the floor is yours.
Thank you, Perry. Thank you, everyone. Just recently, the Josiah Macy Foundation put forth recommendations for addressing harmful bias, eliminating discrimination in health professions environment. According to the foundation, in order to create an inclusive health environment, we must start with an inclusive learning environment. I will highlight 3 of these recommendations for you and give you examples of what we are doing at Indiana University and also within the School of Nursing. So the first recommendation states that executive leaders should create, publicly commit to, and widely promote multi-year strategic plans focused on mitigation of harmful bias and elimination of discrimination. So at the Indiana University School of Nursing, we started our Diversity Council about a year ago. It's led by the dean and includes a diverse group of faculty, staffs, and will soon include students as well. The dean is personally holding herself and her executive team accountable for promoting an inclusive environment for all. Additionally, our dean's leadership in championing of diversity, equity, and inclusion has inspired our faculty's confidence to act. So in a recent university-wide initiative called Creating Racially Inclusive Classrooms, 7 out of the 32 faculty in this inaugural cohort are from the School of Nursing. Over the next 1 year, the faculty will meet virtually for 2 hours each time and reflect on how their identities, lived experience, and worldview affect students' learning. Then they will then use these reflections to revise a syllabus or a course assignment to promote racial equity in their courses. They will also champion inclusive classrooms at the school through peer mentoring and support. We are also aware that recognition and reward is vital to engagement and sustainability of inclusive environments. And to that end, our university has formed an inaugural Public and Engaged Scholarship Review Committee. As you might know, Public and Engaged Scholarship is a growing trend in the 21st century scholarly work. However, the nature of that work is not fully understood by colleagues who are not themselves engaged, publicly engaged. This work is often conducted by women and people of color. Misperceptions among peers regarding the purposes, the processes, and products of diverse forms of scholarship, such as public and engaged scholarship, can lead to negative consequences and impact on the careers of our colleagues who belong to underrepresented faculty groups. So this problem must be proactively addressed at institutional level. It is in that spirit that the university has formed the inaugural Public and Engaged Scholarly Review Committee, of which I am a member. This committee of expert faculty who are engaged in public work will help others on campus to better understand this form of scholarship as faculty members then undergo promotion and tenure processes. The second recommendation from the Josiah Macy Foundation states that health profession schools should co-create with their communities both educational and experiential opportunities to help learners understand the places where their patients live, work, learn, and play. At the School of Nursing, Our students are certainly demanding this. In a recent survey, we asked 130 incoming cohort of master's level students what they know about diversity and what they need in terms of diversity training to care for all patients and build an inclusive healthcare environment. The most common responses were, and I quote, "We want to be in a community of patients that we will serve. We want to understand their cultural experiences, facilitators, and barriers to care. We want professionals from those communities to also come to our classrooms and teach us." I think it is fair to say that it's no longer enough to have clinical placements limited to inpatient hospital settings or just outpatient clinics. And so to that end, we are expanding our community-facing activities across both our bachelor's and master's programs. In the undergrad levels, for example, we have students who are immersed in several community agencies, such as an immigrant center, our publicly funded health systems, but the multicultural services section, as well as county health departments. So what we're striving to do is to help our students not only learn how to take care of patients, as in delivering direct care, but also learn of all of the different multicultural and psychosocial supports that they need to improve and optimize patient care experiences. In Indianapolis, Indianapolis actually has the largest population of the Burmese in the US. And so we have made a strong effort to collaborate with that community and to ensure that our students are ready to serve that patient population and create an inclusive healthcare environment. Additionally, we are engaged with multiple community partners to prepare diverse students who are practice ready to care for all patients. So for example, we have begun conversations with the National Black Nurses Association and the local chapters, and they came to us to ask us to partner with them. And so we are looking to work with them to mentor both our students, but also our faculty, to make sure our faculty have the necessary knowledge and skill to prepare our students for an inclusive healthcare environment. We also hope to recruit students as well as faculty from this association. We also have the largest health system in Indiana approach us to work with us and enhance recruitment, admission, retention, but also graduation and transition of diverse students into the workplace. This is critical to building a cadre of healthcare workforce that will create an inclusive healthcare environment. Our dean has also fully funded 2 diversity postdocs. This is aimed to, 1, increase the number of diverse students from diverse backgrounds in our school, but also to increase research interventions that focus on the unique healthcare needs of diverse populations. We have interviewed for 1 position and made an offer. We have 1 more, and so please let us know if you are interested. There is one area that we just do not do enough of, I think, in nursing and in academia in general. It is critically important that when we disperse our students into the community, that we ensure their safety. So we need to be asking the questions, do our students feel safe as they drive to where they will be doing their clinical experience? Do they feel safe to stop and use a restaurant, or to use the restroom, or to sit, in a restaurant and have lunch, or whatever the case may be? If the answers to these questions are no, then it's critically important that we take a look again in a proactive way to ensure that our students are safe when they go out into the community. Institutions should develop explicit policy and procedures to protect students from any intent to harm or shame students by care recipients. Last but not the least, the third recommendation from the Josiah Macy Foundation states that health profession schools should undertake a thorough review of existing curricula across all subject areas to identify and eradicate radicalized content, such as stereotypes that perpetuate harmful bias and discrimination. And such content should be replaced by material that protects equity, inclusion, and diversity. So at the school, Indiana University School of Nursing, we have a BSN curriculum task force that was launched by faculty on their own. It was prompted by two events in particular. In the first event, this was in a classroom setting. A faculty usually ask students to wear name tags. So one student included a pronoun indicating that he identified as transgender. A faculty member recognized this and applauded the student. Another faculty member struggled with this and said she would not honor his chosen pronoun. In a second event, and this occurred about a year ago, we had a student who identified as transgender was quite vocal and courageous and approached our faculty to volunteer presentations to both student and faculty groups, as well as our diversity council. In addition to that, the racial justice issues, including the COVID pandemic and the glare, the exposure of disparities further strengthened the faculty's commitment and the significance of reviewing our curriculum for inclusiveness. And so the task force was launched and invitations went out to faculty and students. We had 20 students respond, and this typically does not happen. I think it's a clear indication to us that our students are feeling included and also empowered to speak up. Although our faculty struggle and verbally express concern that they might say the wrong thing, they also acknowledge that they need the knowledge and the skills and have looked to our student experts for support in this regard, and our students appreciate this. In addition to the current students, we are also going to invite our alumni who are already in practice, and we will be asking them for feedback on what we did well or may have missed when they were in our program, and to give us suggestions on what we could have done to better prepare them in creating an inclusive healthcare environment. As the chair of the BSN Curriculum Task Force said to me, we are not in a rush to come up with answers. We will look to our students to drive our action plan. Thank you so much.
Thank you, Dr. Aruche. That was wonderful, and there was so much richness in your presentation. As we can see so far, we've gotten some really wonderful perspectives. We've seen from the CDC, and we've seen a perspective from University of Indiana School of Nursing. I'd like to offer one more speaker who's going to give us another really important perspective, and this is Annabelle Castro-Thompson, who is Senior Vice President of Health Equity and Equality Health. Working closely with key stakeholders in the community, Ms. Castro-Thompson has pioneered an innovative, replicable, and sustainable culture care model that establishes equality health as a trusted resource among patients and providers alike. Thank you for coming.
Thank you, Piri. I appreciate the opportunity to be here and to share my cultural care model. I have been working the last 4 years at Equality Health as Senior Vice President of Health Equity, where I lead the cultural care model in our approach to social determinants of health. And today I'll be discussing how I'm creating inclusive healthcare environments. So Phoenix-based Equality Health is tailoring care based upon culture. We manage 215,000 members and work with 5 Medicaid plans in the state of Arizona. We aggregate independent and large providers, but have the industrial strength and process to also service FQHCs, ACOs, and health plans. At the core of Equality Health Approach is our proprietary cultural care model. To create inclusive healthcare environments, our cultural care model heightens the network's conscience over 4,600 providers about cultural values and preferences and assist our healthcare professionals to better understand and more effectively respond to the growing needs of diverse populations. And the cultural care model has 4 foundations. The first one is cultural integration. A growing body of evidence highlights the importance of a cultural competent care, and therefore we embed culture into every aspect of operation. The second is community integration, the importance of engaging on the social determinants of health, and we have created a proactive and systematic approach for this. Our third one is profound member activation capabilities, and our digital strategy ensures that our activities are culturally relevant, they're linguistically appropriate, they're easy to understand, they're action-oriented, and they happen at precise intervals. And last but not least, we do extensive work in practice enablement. We provide technology that's very sophisticated in data analytics. We provide administrative support and operational efficiencies so that our providers are able to focus on the person while successfully functioning in value-based agreements. This model was initially conceptualized to meet the needs of Latinos, but it has been expanded to meet the need of other ethnic minority communities and diverse communities, including African American communities, Asian Pacific communities, and others. The model is grounded on 3 tenets. Culture has real-life implications in the life of members, and it's at the heart of utilization, prioritization, and prevention patterns in underserved ethnic minority communities. Family and caregivers will impact your access and your decision-making, and therefore, our model is not only member-centric, but family and member-centric. And lastly, the SDOH is important. So where you live, learn, work, and play impacts your health opportunities. And so we have created specific assets to address each of this. And there is much more to say about our culturally competent care delivery, but I will focus mainly today on the cultural curricula of the model as the means to improve inclusive healthcare environments. And I will say this, America is becoming increasingly diverse. Our workforce of healthcare providers does not mirror communities served, and health disparities keep growing and becoming more costly. And so in order to build a more inclusive environment, it is imperative to build the cultural competencies of everyone in the network so that providers and ancillary staff can learn to embed cultural preferences at the point of interaction. And we do this through our population-specific curricula, which is both unique in content and in delivery. The content, unlike traditional cultural competence curricula, which tends to be comprehensive, this is specific and it's practical and it's tangible. And it helps providers tactically embed respect, trust, a warmer approach, a more personal approach, a family approach, and shared decision-making into the encounter. We know that the typical visit in the United States with a provider lasts only 9 minutes. And we also know that there has to be trust and a deeper relationship for mutual understanding and for the plan of care to be successful. And therefore, we must teach providers how to leverage the short amount of time they spend with patients on building the relationship so that it leads to improved prescription adherence, greater continuity of care, greater satisfaction, the right use of setting, meaning less of the ER visits, and behavior modification. The delivery is also unique. Equality Health has capabilities to deploy this curricula via LMS, a learning management system, in the computer, but we choose to deploy it live. And we walk into a practice and we sit down the providers, the ancillary staff, the front office, the back office, and the management. And we do this because we feel that everyone in the practice has a role to play to ensure that the environment is more inviting, it's more inclusive, it's more respectful, and it's more customer-centric. We are also firm believers that satisfaction, performance, and quality should not be pinned on the shoulders of the provider. And so we make sure that from the moment the patient walks in, the environment feels different. Today, we have created over 31 modules. We focus on 7 specific populations. We have trained roughly 9,500 providers and staff, and we have achieved close to a 90% satisfaction on the curricula. For those of us that develop curricula, this is unique, and we are tremendously proud of this. We operationalize these trainings by making the curricula mandatory for entrance into the network. Each practice that comes into the network must go through a 4-hour onboarding. And while most of the curricula is cultural in nature, we also teach the practices about population health, care coordination, how to succeed in value-based agreements, how to assess and address for the social determinants of health. How do you use the digital technologies that we're putting at their disposal? And so every year too, after that, providers must also choose an additional module of cultural curricula to undertake, because we want to continue to build their cultural competence. Providers and staff earn CMEs and CUs for going through the training, and they also receive monetary compensation for their time. Providers, furthermore, take a baseline assessment to measure cultural competence, and we are constantly building curricula based on the opportunities observed on this assessment. And lastly, we deploy a proprietary tool which we called the Social and Cultural Risk Assessment, and we endearingly call it SUCRA. SUCRA is a 15-item Likert scale test that assesses for the typical social determinants of health. Do people have transportation? Do they have housing? Do they have food insecurity? Do they have job opportunities? Do they seek educational opportunities, etc.? This tool also assesses for cultural elements, beliefs, values that are known to hinder utilization. If we believe so strongly that culture impacts utilization, then we need a form to assess it. The tool also assesses some behavioral health or mental health. It does physical activity, sense of well-being, and spiritual needs. This tool has partial validation. We have a longitudinal relationship with Arizona State University, and we have partial validation. And we have found that 5 of the questions contained in this tool are statistically significant for 3 or more ED visits per year. And so it's tremendously powerful to have this information. This tool is being given by the provider, and we incent the provider to put this tool in front of the patient every time they come into a visit. This allows us to assess for emerging SDOH needs, but also to assess for emerging costs before they show up as claims. Once we assess for needs, we can refer to our curated network of social services who have partnership agreements with Equality Health, and they also have performance standards, and so they have to meet the needs of our members in a timely manner. I will also say that to our CVO network, we provide a very sophisticated technology through a third-party vendor, which allows them to collaborate and communicate. Through this technology, it allows portability of the social record to all the CVOs in the network. And so the CVOs can see all the activities, all the communication, and who is working on behalf of the patient to meet the needs. Specific to this technology is that one global consent allows for portability of the record for everyone to be seen. And so while we pay for the technology, we tell the CVOs, use it to meet the needs of our memberships, but also use it to meet the needs of the community as a whole. And I will tell you that it has been so powerful, this technology, that 2 of the community-based organizations in network have completely abandoned their management system and are loading everyone into this device. Finally, I will say that we work in tandem with the practice enablement team. They are redesigning workflows and operations in the practice. We are redefining the encounter. Our combined efforts are part of the larger approach towards practice transformation and healthcare redesign. We are undertaking at Equality Health to promote equity and also to decrease healthcare disparities. Thus far, our quality has improved and our costs are going down. We are successful in part because we have aligned activities with monetary incentives. We incent for the cultural curricula. We incent for SUCRA to be done at the visit every time, and we incent for coding of SDOH. We pay our providers quarterly incentives so that it's closer to real time, and we give them our report and feedback, which includes all the activities that providers have undertaken to earn the incentives. And when I say providers, I'm talking about both medical and behavioral health providers. This has provided greater transparency in the work achieved. Our cultural care model, however, also calls for extensive work in the community. And so we undertake extensive collaboration with community-based organizations and with grassroots groups to host and support webinars, virtual town halls, provide bilingual education forums, provide health fairs and health festivals prior to COVID, and even to launch large-scale testing during COVID in underserved and under-tested communities. And so it is part of our model to be member and family-centric. We deliver population-specific strategies in the community, and we ensure that the consumer understands what we are doing and how we are transforming the healthcare experience for their benefit. And I will say a little bit more as it relates to our COVID efforts. During the pandemic, we brokered a large coalition of governmental, private, and public entities, and we formed a partnership and a coordinated approach to serve underserved and under-tested communities. We called this model RAPID because it was respectful, it was action-oriented, it was proactive, it was inclusive, and it directed you towards the right resources, whether it was healthcare or social services. The model has a heavy emphasis on education, on viral testing, on follow-up care, mass distribution, connection to essential social services, and also contact tracing in underserved and under-tested communities. This fall, these efforts are evolving to also include flu vaccination as well as children vaccination, because in Arizona and across the nation, vaccine rates have plunged since COVID. So through our coalition, we have tested over 7,000 Arizonans, and our efforts will continue well into the fall and winter. Because of our cultural care model and our inclusive care design, Equality Health is increasingly seen as a leader in healthcare and as a leader in engaging underserved and ethnic minority communities. Ethnic minority communities have a saying, I don't care what you know until I know that you care, and they know through our cultural care model that we care. Equality Health in our cultural care model is both a trusted resource in the community and is seen by both members and providers alike. Thank you.
Wow. Wonderful, wonderful, Annabelle. That was just an amazing presentation. I don't know about everybody else, but I'm feeling very, very inspired. Before we close today, I would like to give each of our panelists today the opportunity to answer a question. And so I'm assuming that people that have joined this session are interested in how they can make their healthcare environments more inclusive. So given your unique vantage points, what pearls would you have for people who would like to leave this session today and make a difference at their organization? How can they begin to make changes at the individual level? And understanding that institutions are made up of individuals, how can someone leaving this conference today get this work started or create more momentum around inclusion? We'll start with you, Dr. Birchall-Foe.
Sure, thanks for the question, Piri. I think it all starts with communication. So being able to recognize that staff have a voice or individuals have a voice in any organization, and then giving that ability to share that voice. So whether it's through a working group or through an all hands or just even individual one-on-one with key leaders, I think that's probably the most important thing that we can do to we can at least start off to answer your question.
When we talk about inclusiveness, it's really about who we say we are or want to be. So using that lens or that language when we talk with individuals, I think is important. Just a reminder, this is about who we say we are and want to be. I think you'll be hard-pressed to find an institution that does not, whose mission statement doesn't, indicate a desire to include others. The second thing that comes to mind is a recognition for when people do, or as individuals, we do get involved and participate in trainings and all kinds of initiatives, such as the Creating Racially Inclusive Environment that I talked about, that we are that we're championing at our institution at Indiana University. Having a way to make sure people have the time to get involved in those kinds of activities, but also recognizing and rewarding the time and effort that people put into it as well, I think is really important.
I think as us nurses are caring individuals, and we need to be at the forefront and we need to be included in decision making because we are great advocates and we are great educators, and we understand our communities better than anyone from being at the bedside. I, however, think that in order to provide more inclusive and more holistic health from an enterprise perspective, we definitely need to integrate medical, behavioral, and the social determinants of health in healthcare. And when we do this, we need to build the competencies, the cultural competencies of everyone in the network so that they learned how to assess and how to address patients from a cultural standpoint at the point of care.
Thank you. Such great points. So we've had several recommendations. One, hearing the voices of our employees, really paying attention. We also have living up to our mission and our values and recognizing the important work that people are doing on the ground level. And then we had talking about how nurses are poised and are at the forefront of a lot of the activities to move equity forward. And that while nurses are at the forefront, we need to honor the expertise of communities and also the value of the diversity that brings. Thank you so much. This concludes our panel today. I would like to thank the Academy for including this very important topic in the agenda. I would also like to thank our staff producers. And again, thank you to all the panelists. Have a good day. Hello, everyone, and welcome to the live portion of our session. I hope that you enjoyed the recording. And now this is a time where we can some interactive conversation with our panelists. I just wanted you to know that Joseph Bertulfo was not able to make it because he is out in the real world actually saving the world. So we will miss him on our panel today, but we still have some wonderful panelists, and I'm going to begin asking some questions. I'm going to start with you, Dr. Aruche. My question for you is, give me just a second. How can the nursing profession help build and support the pipeline of future faculty and clinicians who are more representative of the diverse student and patient populations we serve?
Thank you so much, Piri. I would start by saying we as nurses have to be very proactive. So by that, I mean, we are not waiting for when students apply, but we are actually going out into the communities where our patient populations come from. So it's as simple as being visible in elementary schools and high schools. I have heard of a colleague who was in an elementary school doing some work in social and emotional health and did a survey and asked the students, these are elementary school students in the 6th grade, what do they want to do in the future? And the students, at least some of them, were talking about being a certified nurse assistant, which is good. But I think the presence of professionals such as us will help students to see they can aim for higher. They can become professional nurses. So that type of proactive work with elementary schools in the community is critical to building trust. What that does then is to provide educational information so that our students are prepared to apply and successfully matriculate into schools of nursing. And of course, we want to, once they come in, to provide whatever supports that they need to be successful, to progress, to graduate, and of course, intentionally building in mentorship supports to ensure that they transition successfully into the workplace. Thank you.
Wonderful. Such great recommendations, Dr. Aruche. I really appreciate that. Dr. Castro Thompson, I have a question for you as well. My question for you is, what recommendations do you have for others who would like to provide culturally competent care training within their own organizations for employees and providers?
Sure. Thank you for this question, Piri. I see it a lot, particularly with our curricula being so unique and innovative. Some things to keep in mind is our business model particularly came into a market which was very saturated by large ACOs and health plans. And I will tell you that from a curricula and cultural competence perspective, if QHCs have different mandates as to the curricula that they have to consume in regards to cultural competence training, Medicaid plans have curricula that they, in part, have regulations that providers must take. CMS does the same thing, and then other health plans themselves have created their own specific curricula. And so providers are saturated and often overwhelmed by the amount of training and expectations. And so we must recognize that allowing them or asking of them to take even more curricula, there has to be something specific that we must be asking of them. We also need to recognize, however, I would say that not all cultural competent curricula is the same. As a provider myself, I have taken many curricula through our lifetime. And I will tell you that oftentimes, or many times, the cultural competent curricula was so broad and comprehensive that I walked away understanding that I needed to be aware and respectful of differences, but I didn't know how to tangibly embed it into practice. And so in our case, that's precisely what we've done. We've taken information that's already found in evidence-based research, we ingest the information, and then we package it and we make it very consumable to providers. They say that evidence-based research takes approximately 17 years or 19 years, right, to make it to care delivery. And so what we've done is we've expedited the time limiting element so that providers have access to this information. So we tell our providers, we know providers are very busy. They're busy concentrating on patient care, and then there's a large portion of documentation. So we ask them, do you know, have you read the literature on how to embed trust and respect and all these wonderful things into your encounters? Do you know that the provider visit usually lasts 9 minutes? Would you like us to teach you how to leverage the short amount you have with patients? And really what we've created is curricula that it's best practices, it's tips, and it's tricks. And so it's very unique. And then subsequently, we pay our providers, we compensate them for the time that they spend with us learning this curricula. So I will say I probably have 3 pearls of wisdom for those that want to create new curricula. The first one is make it consumable, make it bite-sized, right? This is how you need to do it in practice. By the time you take this module and you leave, these will be the 5 tangible things that you can implement now in your practice for X, right? In addition to that, take into account the preferences of the providers. I mentioned in my presentation, we have 4,600 providers. I send a list to all the providers every year, and we tell them these are the types of topics that we are considering for research and development. Which ones would you like to hear more about? And I will tell you that when we create a specific module, it's population specific. So this year, for example, probably because of the larger conversations that are taking place across the nation, we are going to tackle unconscious biases, but we are going to do it population specific. So I'm going to tell you about unconscious biases specific to the Latino population, to the African American population, to seniors, to young adults, etc., so that providers then know how to implement it differently. And the other one that we're going to be doing is racism in medicine. In addition to that, I would say pearl number 2 is train everyone. Providers, by the nature of our license, we get a lot of training in cultural competence. Oftentimes, though, the MAs and the practices, the front office, the back office, the management, they have never seen this type of training. And so we believe that everyone has a role to play, right, in making the delivery more cultural competent, which means that it's more inclusive, it's more respectful, it's more customer-centric. And so find a way to involve everyone, even if you have to tie compensation for it to happen. You will notice that the MAs, the front office and back office, are often overworked, overloaded, and exhausted, and they welcome these types of learnings. And then the last one I've already mentioned, but let's tie incentives to action in the practice so that change sticks.
Thank you so much, Annabelle Castro-Thompson. You provided us with some great insights into the what in culturally competent care training and inclusivity training and the how, and that's really helpful. The next question is for Dr. Aruche again. What best practices or recommendations do you have for others who would like to implement diverse worldviews, lived experiences, and peer mentoring into their classrooms to help facilitate inclusivity?
Thank you for that question, Piri. I mentioned during my presentation about a university-wide initiative that we started at IUPUI. it's, was titled Creating Racially Inclusive Classroom. It was at the university level, but as I indicated, a number of our faculty from the School of Nursing tapped into that. I don't think there's any need to reinvent the wheel in creating these kinds of programs. I would reach out to other schools who are doing it to see what kinds of programs they already have in place and how you may then adapt it. Consistent with that question, the program is designed to help all faculty reflect on how their own personal identities, lived experience, and worldview impacts our student learning. So again, no need to reinvent. Participate, and please recognize the faculty's efforts as you do annual performance reviews and factor that into promotion and tenure. We want to recognize what people are doing so we can inspire them to continue to do that.
Thank you, Dr. Aruche.
Thank you.
We have another question for you, Annabelle Castro Thompson. My question for you is, nurses are trusted providers of care. Can you discuss how important that trust has been during the pandemic and helping community members, especially Latinx, feel comfortable to come forward for testing and resources?
Yes, thank you, Piri. I'll start by saying that nurses are indeed trusted entities. And I will tell you, in my community, nurses are everywhere. But I also want to highlight the efforts of the National Association of Hispanic Nurses and the National Black Nurses Association. We are deeply embedded in our communities, and we are everywhere, particularly during these COVID efforts. I think we know well that as nursing leaders, it is important for us to be present, visible, and accessible. And so I do know that nurses, we are caring individuals, and we are both in the front lines and behind the lines, ensuring that vulnerable populations and communities of color get the care that they need right now. Increasingly, within our nursing profession, I am seeing nursing leading in changing the paradigm and ensuring that equity, diversity, and inclusion, and even equity frameworks and cultural adaptability is included into everything that we do out in communities, particularly hard to reach populations, because it's important and it's necessary. And so at the beginning of COVID, I live in Arizona. Latinos were not well represented in testing, and there was little known about our positive or testing infection patterns. Yet we knew that because Latinos were essential personnel and because we do a lot of work in health disparities, we knew that they were going to be deeply impacted. Our efforts started in May, just as Arizona was the hotspot in the nation, and Latino communities, I can tell you, were well under-tested. And so through our cultural care model, which I would say is rooted in many of the nursing principles that we learn as nurses, we broker a coalition of community partnerships to create a targeted, coordinated approach. I spoke about this approach during my presentation about how it was called RAPID, because it was respectful, it was action-oriented, it was proactive, it was inclusive, and it directed people to the right resources. So I will tell you, when some other efforts were taking place in our communities, for example, they were demanding registration ahead of time. We came in and we said, that doesn't work for hard to reach and vulnerable populations. We understand that in order to accelerate the drive-through mechanisms that we have in place is important, but let's make it recommended rather than mandatory. We also knew that while testing was important, giving test results alone was not going to change contagion in our community. And so what we said is, okay, yes, let's test, but let's make sure in the back end we have somebody calling people who are positive because they need specific instructions as to how to keep their family safe and when to return to work. And so in many ways, I think that nurses are trusted entities because we know and we understand our communities well. We're used to educating and advocating for the vulnerable in our societies, and we do it every day. And most importantly, during COVID, we put our training and our expertise into action. And so this and other attributes make us the right conduit to ensure that we have gotten resources, testing, and everything else that vulnerable and Latino populations and other populations need.
Thank you so much, Annabelle. And I would like to extend a special thank you to our panelists for your expertise, your wisdom, and for your insights. This has been a really special presentation. I also want to thank all of our audience for joining our session. I want you to know that we are in unprecedented times with the things that we are trying to solve in healthcare. Nurses are uniquely poised within the healthcare system to make change. We can do this. Our panelists have given us some insights about how we can do this. And so my hope is that everyone will go out and use action steps to make change in our health outcomes. And with that, I want to say thank you to everyone for joining.
It is my honor to present this year's Lifetime Legacy Award. This award recognizes an extraordinary individual who has dedicated their life to advocating for positive health system changes. This year, the Academy is thrilled to honor Dr. Patrick DeLeon for his distinguished career as a fierce advocate and policy expert for quality healthcare reform. From supporting the nursing profession to advancing monumental changes for mental health services, he has been a genuine champion at the highest level. Dr. DeLeon began his career working with Senator Daniel Inouye, first as an intern and continuing on his staff after graduating from law school, eventually retiring almost 40 years later as his chief of staff. During their decades-long tenure together, they advocated tirelessly for improved care for children and families and to ensure that healthcare professionals could practice to the full extent of their training. The nursing profession owes a debt of gratitude to Dr. DeLeon. He helped to spearhead countless legislation to support nurses. Most significantly, and one course-altering moment for the profession, Dr. DeLeon was instrumental in the establishment of the National Center for Nursing Research and later the National Institute of Nursing Research within the National Institutes of Health. He always knew the importance of nursing and inserted our profession into critical policy conversations when we were not physically at the table. After Dr. DeLeon's daughter became critically ill in 1984, he and Senator Inouye worked to support the Emergency Medical Services for Children program to guarantee that emergency departments are equipped to handle infants and their families in times of critical need. Dr. DeLeon and Senator Inouye were largely responsible for a 1988 legislative measure that authorized psychopharmacology training for United States Department of Defense psychologists. Importantly, around the same time, he worked to secure prescriptive privileges for nurse practitioners. Dr. DeLeon has held numerous roles within the American Psychological Association, including on the board of directors and serving as president in 2000. In 2019, he was recognized with the organization's highest award, the APA Award for Lifetime Contributions to Psychology. He won the inaugural Advocacy Award from the National Council of Schools and Programs of Professional Psychology in 2004. Dr. DeLeon has a strong commitment to mentoring students and supporting future health policy scholars. Since 2012, he has held a distinguished professorship in health policy and research at the Uniformed Services University of the Health Sciences and has been an adjunct faculty member at Vanderbilt University, Widener University, and the University of Hawaii, campuses in Hilo and Manoa. As a member of the Institute for Nursing Leadership's National Advisory Council, Dr. DeLeon made sure that his students from USHUS had the opportunity to attend the INL session. Dr. DeLeon is an honorary fellow in the American Academy of Nursing and, as I mentioned, a longtime champion of the Academy through the role on the Institute of Nursing's Leadership National Advisory Council. Congratulations, and thank you, Dr. DeLeon, for your lasting impact.
Aloha. I was very pleased to receive a letter from your leader, Dr. Sullivan Marks, and for decades we've been pleased to work closely with nursing's leadership. A number of friends over the years, Ada Sue, Pat Grady, now at Uniformed Services, Carol Romano, Diane. And we have a wonderful profession. You truly serve the nation. And for over 4 decades, we've been very pleased to work closely with your leadership and try to facilitate your ability to provide the quality care and the research that the nation needs. My sincerest appreciation and congratulations to you. This has been a wonderful end of my career in terms of the Hill, and now I have a chance to teach the next generation of your leadership at Uniformed Services University as to the intricacies of the public policy process. A number of us have dual degrees, and I'm particularly pleased to see the extent to which we've never forgotten why we entered our profession, and that is to serve society. Aloha, mahalo. Thank you.
Hello, everyone. I am so thrilled that our fellows and attendees are gaining so much insight from our very first virtual policy conference. The speakers have been exceptional, and I believe the conference planning committee, led by Drs. Mary Gillette and Pam Jeffries, were exceptional in their ability to reach our purpose statement for this conference. Provide participants with the knowledge and insights that can be translated into innovative, creative, and sustainable change for the individual, team, and organizational environments for policy impact. While I so miss the conversations with fellows in person and seeing so many of you here in Washington, D.C., it always provides me so much energy and encouragement. I see you all online and sending messages and engaging in new ways. I also have to share that this is a really powerful moment for us as staff. Typically, we'd be running around, answering questions, taking registrations, and making sure attendees had everything they needed. While there is still quite a bit of that, we are a little bit more relaxed for right now. And for those of you that know me, I have my hair down today. But in all seriousness, we as staff are also having an opportunity to fully watch the sessions. And as an Academy team, we are renewed and could not be prouder of this incredible organization and profession. The content was rich and thought-provoking today. We as staff will also be certainly looking into the interim final rule that the Office of the National Coordinator has put out. One message that I took away was safety. In a digital world, in a COVID world, and a world working to eliminate racism and discrimination. Dr. Pertulio Bert Tufol talked about how to keep workers safe and the role of occupational health nursing, reinforcing the value of flexibility. We must also look at the next generation of nurses and keeping students safe while they're in the community. Dr. Okumako Urichi's example of a transgender student and their choice of pronouns reminds us the important responsibilities of academia to understand, support, and protect not just our students, but the patients they will ultimately serve when they're in practice. Dr. Castro Thomas discussed safety in the respect of building trust through engaging families and shared decision-making. The Academy considers safety in our policy work, but we also know the great importance of creating safe spaces for dialogue. We hope that you continue to connect and discuss. In my reflection room last night from the INL Critical Conversation, Dr. Catherine Alicia Georges said, and I'm paraphrasing, that if in your effort to understand, you do so by building trust and listening, it will be felt and great progress will be made. One thing that I hope the fellows and attendees appreciated was the mindful moment that Dr. Kate Fitzpatrick shared with us today. As we look to create safe spaces, work to protect our communities, and we also have to be centered ourselves. Thank you, Kate, for leading us through a truly beautiful moment to find gratitude. I am grateful for this opportunity to be together. Up next, as you know, are our policy dialogues, where our expert panels have been planning to share their expertise and insight with all of you as attendees. Later this evening, I am thrilled to be able to celebrate with all of you the 5 incredible living legends this evening. I want to take a moment and make sure that all of you take the time to look at our awards section as well. You just heard Dr. De Leon receive one of our Academy Awards, but you'll also see the Nursing Outlook Awards and one of our Edge Runners. It's a really incredible opportunity to see all the remarkable work and great contributions that nurses and fellows within this organization have made. I'd also like to say on behalf of the Academy staff and the Board of Directors, we welcome all of our international fellows around the globe. I have seen so many chats come in through the discussion, and we're so glad to have you and welcome you to this discussion. Finally, I want to thank so many who have supported this organization in so many ways through their time, their treasure, and their commitment to building a greater academy and our greater impact. For those of our fellows who are in the President's Circle, thank you so much for your generosity and your support, and all of those who have donated to the Academy. In closing, I just want to share my gratitude to each and every one of you for being here and being with us. And thank you for your participation in Day 2.
Thank you for joining us during these engaging panels. Coming up next at 2 p.m. Eastern Time are the concurrent policy dialogues. Navigate to the agenda page and choose one of the 3 sessions to hear from leaders and engage in breakout conversations. At 6:30 p.m. Eastern Time, the Living Legends celebration will be streaming live on YouTube. You will receive an email with the YouTube link to share with family and friends. See you tonight.
is Nate Martinez, and as part of the American Academy of Nursing 2020 Virtual Policy Conference, I am here to facilitate a sound meditation for you as part of a wellness experience. So if you're wondering, oh, I've never meditated before, I don't know how to do it, the great thing about sound meditation is that you don't need to know how to do it. you already know how to listen. And so I'm going to provide just a brief amount of context for you, and then we're going to move into the sound meditation. So first things first, you want to be able to hear the audio clearly. You don't need to pay attention to watching the screen, because in a moment we're going to be closing our eyes. The other thing that's important is that you actually are comfortable. So if you're in a seated position, just making sure that you are supporting your posture. And if you want to, you can lay down. You can lay down on a couch, recliner, bed, floor, wherever you're going to be comfortable. And what I want you to do is just begin to get into that perfect spot that you're going to be for the next 15 minutes. And as you do begin to settle into that position, the next thing that you're going to do is close your eyes. If you have glasses on, you can take your glasses off and put them next to you. And you're going to close your eyes, and the first thing that we're going to do is begin to connect with our breath, natural breathing, not taking any deep inhales or exhales, just simply inhaling through your nose and exhaling through your mouth. And just beginning to connect with your breath's natural rhythm. Inhaling through the nose and exhaling through the mouth. And as you continue to attune to this breath and its rhythm, I'm going to explain just a few things and we'll begin. So, at its core, this experience is about deep listening. You're going to be experiencing sounds coming from instruments in my studio, as well as sounds happening naturally in your home environment. And given that we're all in different environments, it's going to lend itself to a different experience. So it might be more active, could be street noise, voices, footsteps, or maybe depending on where you are, it could be nature related. Maybe it's wind or rain, or just birds. So regardless of where you are, it's just about you bringing wherever your awareness is being brought to at any given moment with any sound, trying to incorporate it into your listening experience. The more you're able to do that, the more you're able to sustain this present space that you're going to be exploring for the next little bit. If you find that a sound is a trigger, or a thought, or a memory, or sensation, or an emotion, come back to your breath, that breath that you're connecting with right now. Simply returning to it will provide you a focal point that you can then begin to work with and through whatever may be arising. Now, at the very end, I'll lead each of you back, so you're really free to just close your eyes and begin to listen and become your own witness, exploring not only your environment, but your inner universe as well. So begin taking a few deeper breaths now, still inhaling through your nose and exhaling through your mouth. Filling your lungs to the natural capacity and then releasing and repeating. And after you complete that next exhale, just beginning to return to relaxed breath. Eyes closed, just beginning to expand your listening and exploring your environment. With your eyes still closed, just begin to take some intentional breaths, inhaling through your nose and exhaling through your mouth, drawing some more oxygen into your lungs and then releasing and repeating. The exhale, if you feel comfortable, letting out a sigh or a sound. Take a couple of these deeper releasing breaths. And at the end of that next exhale, just beginning to slowly open your eyes with a soft gaze, easing your way back into the space that you're in. And just taking a moment to extend this space that you've created for yourself. On behalf of Mindful Meditation and myself, we are extremely grateful for everything that you do and hope that you have found this brief moment of pause to be helpful. Thank you. Be well.